morning में आज we had a session on adrenal insufficiency, made the professor session. Me, Dr. Abdul Hamid Zargar and Dr. Paul Stewart from Leeds University, England, talked about and discussed some cases of adrenal insufficiency. And conventional adrenal insufficiency and whatever diseases cause it are very well known, and Paul did talk about them. But I try to tell the audience our own Indian perspective. If you look at it today, a huge number of patients in our own country are wittingly or unwittingly given steroids. They take them off, they take them on, and whenever the steroid intake is beyond a particular point, and if it is withdrawn, a person is liable to suffer from secondary pituitary adrenal insufficiency. And this is a significant problem in the Indian subcontinent. We have seen lots and lots of the so-called iatrogenic Cushing's. When you attempt to withdraw those steroids, leading ultimately to Addisonian disease. In some patients, the disease is bad enough that it needs replacement, but in others, there might be some semblance of a reasonable cortisol dynamics, but complete recovery does not occur. And in these people, under routine circumstances, they may be able to maintain their cortisol status. But whenever they are subjected to citrus, their inability to increase the level of steroids, cortisol in particular, during the stressful period, let's say an overwhelming infection, trauma, surgery, which increases on an average 3 to 5-fold, does not occur. So such people stand a chance of getting some semblance of adrenal crisis during this stressful period. The second component that I did allude to is that infections have been shown to involve adrenal glands. So many fungal infections in the Western world, people with HIV have been shown to have involvement of adrenal glands. But in the Indian subcontinent, we have seen, documented and published many cases of tuberculosis. One where there was overt adrenal disease, adrenals were involved, we have documented adrenal calcification, we have documented on ACTase stimulation, adrenal insufficiency, Addisonian disease. But again, there is a big cohort of individuals that if you look at 1/3 of patients who have been treated for tuberculosis will have suboptimal response to ACTH. 2/3 will not. These people under normal circumstances again would be eucortisol during treatment, during routine life. But whenever exposed to citrus, they will get a hypocortisol state. Third, and the most important thing that is unique to this part of the world, is central hypocortisol state where you have an ACTH deficiency. And we have documented huge number of patients with postpartum pituitary disease. We have myriad number of cases of this disorder which presents as Addisonian crisis with central hypothyroidism, and they will not have conventional second pigmentation because ACTH is almost absent in them. So you need a high index of suspicion in people who have some hypertension, grossly sick, or metabolic abnormalities which suggests electrode abnormalities which suggests possible hypocortisol state, but do not have second pigmentation. But if it happens to be a lady, if there have been any menstrual irregularities, if after the last delivery she did not resume her menstrual cycle, Addisonian crisis because of a central hypocortisol state attributable to so-called quote-unquote Shihano syndrome should be discussed. So these are some of the particularly important Indian components which would not be seen in the Western world that we as medical professionals need to keep in mind. One of the most important things is topical steroids, whether you apply them to the skin. But most importantly, in our country, we use a lot of steroids for skin infections, rheumatological disorders, even lung disorders. We have so much pollution in the country. We have so many lung issues in the country. A big chunk of young and adult population has some breathing problem. So massive use of inhalation of steroids also has, if it's unregulated, has a potential of causing suppression of hypothalamo-pituitary adrenal axis. And the moment we withdraw it, the person will have Addisonian disease or will have some form of a hypocortisol state. This is something that is evolving and that needs to be kept in mind. Thank you.